Let me tell you about one of my patients. I will call her Carol. She was 71 years old, sharp as a tack, bright, and every single morning she would turn on the radio to catch the news, and she remembered the name of every grandchild and every one of their birthdays without ever glancing at a calendar. Her daughter called her the living encyclopedia of the family. Then, about 14 months after her doctor added a new medication to her daily routine, her daughter called me in tears. Carol could not remember whether she had eaten breakfast. She got lost driving home from the grocery store she had been going to for 15 years. She asked the same question 3 times in a single short conversation. Her neurologist suspected early-stage Alzheimer's. The entire family was devastated. But here is what nobody told them, and this is what I need you to hear right now. Carol did not have Alzheimer's. The problem was sitting right there in her medicine cabinet. When we went back and reviewed her full medication list and made carefully supervised adjustments with her doctor, Carol started coming back. In less than 5 months, she was back to listening to the radio every morning and reminding her grandkids of their own birthdays. This is not a miracle story. This is preventive medicine. And today, I am going to walk you through the 9 most common medications that could be quietly and invisibly stealing your memory, ranked from the most commonly overlooked all the way to the most dangerous combination that most doctors never warn you about. Stay with me all the way to number 1, because number 1 is not a single medication at all. It is a hidden trap that is affecting millions of older adults right now, and almost nobody is talking about it. Important note before we begin. Before we get into this list, I want to make one thing very clear. I am not telling you to stop taking your medications. Please do not do that without talking to your doctor first. What I am saying is that you have every right to ask questions, to understand what is going into your body, and to protect the health of your own brain. Knowledge is not dangerous. Silence is. And if you are watching this video right now, go ahead and drop a comment telling me what medications you are currently taking. I read every single comment, and your story might help someone else who is watching this today. Number 9, diphenhydramine. All right, let us start with number 9. I want to ask you something honestly. Right now, do you have a box of Benadryl sitting in your nightstand drawer? I am guessing a lot of you are nodding, and I completely understand why. It is cheap, you can buy it without a prescription, and the label says right there, sleep aid. Sounds harmless enough, right? But here is what that little pill is actually doing inside the brain of someone over 60. Diphenhydramine belongs to a drug class called anticholinergics, and that name is going to come up a lot throughout this video, so keep it in mind. Anticholinergics work by blocking a neurotransmitter called acetylcholine, which is the brain's primary messenger for forming memories, staying focused, and keeping you alert. When you are young, your brain has plenty of acetylcholine to spare. But once you are past 60, that baseline level is already lower. Every night you take a Benadryl, you are blocking even more of it, and the cumulative impact over time is significant. What makes this even more concerning is that diphenhydramine hides inside dozens of products you would never think twice about. Anything labeled PM, nighttime relief, or sleep formula almost certainly contains diphenhydramine. If you need something for allergies, ask your doctor about newer antihistamines like loratadine or cetirizine. They do not enter the brain the same way. And if you need help with sleep, we will talk about safer options later in this video. Number 8, proton pump inhibitors, PPIs. Next up is number 8, and this is one of the most overprescribed medication categories in the entire world. Let me ask you something. Are you taking an acid reflux pill every single morning? And have you been doing it for years without anyone ever suggesting you try to stop? Proton pump inhibitors, or PPIs, reduce stomach acid. That sounds straightforward enough, but here's the problem. Your stomach acid also has a critical job, and that job is helping your body absorb vitamin B12 from the food you eat. And B12 is not optional when it comes to your brain. It is absolutely essential. A deficiency in B12 is directly linked to memory impairment, depression, nerve damage, and a pattern of cognitive decline that looks so much like early Alzheimer's that even experienced physicians sometimes confuse the two. A study published by Johns Hopkins University involving more than 68,000 older adults found that long-term PPI users had a 44% higher risk of developing dementia compared to those who did not use them. And it does not stop there. Research has also shown that PPIs may accelerate the buildup of amyloid beta plaques, which is the toxic protein accumulation considered one of the defining features of Alzheimer's disease. If you are on PPIs long-term, talk to your doctor about gradually tapering off, using an H2 blocker like famotidine as a bridge, and make sure you are getting your B12 and magnesium levels checked regularly. Number 7, bladder control medications. Number 7 genuinely frustrates me, and not because of the medication itself, but because of how little patients are told about it. An overactive bladder is a real problem. It is embarrassing, it disrupts sleep, and it affects quality of life. So when a doctor hands you a prescription for oxybutynin and tells you it will help, of course you take it. What almost nobody explains is this. Oxybutynin is one of the most potent anticholinergic medications in common use today. It does not just act on your bladder. It crosses the blood-brain barrier with remarkable ease and directly interferes with the same acetylcholine system responsible for your memory and your ability to learn. A comprehensive study published in the British Medical Journal out of the University of Nottingham found that older adults who used strong anticholinergic medications like oxybutynin for more than 12 months had a 49% higher risk of being diagnosed with dementia, nearly 1 in 2 people. And what makes this particularly heartbreaking is that the early cognitive symptoms, forgetting appointments, misplacing things, losing words mid-sentence, are almost always chalked up to just getting older. The medication never gets questioned. The good news is that newer bladder medications like mirabegron work through a completely different mechanism and carry significantly less cognitive risk. If you are on oxybutynin and you have noticed any mental changes, please have that specific conversation with your urologist or your primary care doctor. Number 6, benzodiazepines. I want to pause here for a moment because this next category is one that a lot of people have very strong feelings about, and that is completely understandable. Benzodiazepines, or benzos, have helped millions of people manage severe anxiety, panic attacks, and sleep disorders. For many people, they felt like a lifeline during an incredibly difficult time. I am not dismissing that. What I am asking you to do is hear the science. Benzos work by amplifying a brain chemical called GABA, which is your brain's natural calm-down signal. They are very effective at producing short-term relief. The problem is what happens when that mechanism stays switched on for months or years at a time. A study tracking more than 9,000 older adults over 6 months, published by the Harvard T.H. Chan School of Public Health, found that those who used benzodiazepines for more than 3 months had a 51% higher risk of developing Alzheimer's disease. The risk was highest with long-acting formulations like diazepam, which accumulate in fatty tissues, including brain tissue, over time. And here is the trap. When you try to stop, the rebound symptoms can be far worse than what you started with. That makes the drug feel necessary even as it is contributing to the problem. This is important. Never stop benzodiazepines abruptly. That can be medically dangerous. Work with your doctor to taper off slowly and under proper supervision. Number 5, statins. Before I get into this one, I want to be clear that statins genuinely save lives. Cardiovascular disease is still the leading cause of death in adults over 60, and for many patients, statins are appropriate and important. But here is what your cardiologist may not have mentioned. Your brain is made up of nearly 60% fat. Cholesterol is not the villain in the context of the brain, it is a structural necessity. It forms the myelin sheath, which is the insulating layer around your nerve fibers that allows signals to travel quickly and efficiently. When you aggressively lower your body's cholesterol with a statin, you risk crossing a threshold where your brain no longer has what it needs to maintain its own architecture. The FDA actually updated statin labeling back in 2012 to include warnings about memory loss and confusion as potential side effects. An analysis conducted by the Mayo Clinic published in Frontiers in Aging Neuroscience found that adults over 70 who took high-dose statins continuously for more than 3 years showed a measurable increase in mild cognitive impairment compared to non-users. And here is the important distinction. Not all statins carry the same cognitive risk. Some types, like simvastatin and atorvastatin, cross into the brain more readily. Others, like pravastatin and rosuvastatin, have shown significantly less impact on cognition in comparative studies. If you are on a statin and you are noticing brain fog or memory changes, ask your doctor whether switching to a different type of statin might give you the same cardiovascular protection with less impact on your thinking. Number 4, amitriptyline. This one surprises people every single time I bring it up because amitriptyline is very often prescribed for things that seem completely unrelated to psychiatry. Nerve pain, chronic migraine prevention, fibromyalgia, even insomnia. It is an old antidepressant that has been repurposed over the decades for all kinds of conditions. Doctors sometimes choose it specifically because it causes sedation, using that side effect as a feature to help patients sleep. But here is what makes amitriptyline particularly dangerous for aging brains. It is one of the most potently anticholinergic medications still in widespread use today. Its affinity for the receptors in the brain where acetylcholine does its work is extremely high, higher than many bladder medications or allergy treatments. A landmark study published in 2015 in JAMA Internal Medicine followed more than 3,400 adults aged 65 and older over a 10-year period and found that high cumulative anticholinergic exposure with amitriptyline among the top contributors was associated with a 54% greater risk of dementia. And what troubles me most is how invisible the damage is. There is rarely a dramatic warning sign, just a slow, quiet erosion. Difficulty finding words, problems with sequencing, a gradual inability to hold complex thoughts, all written off as normal aging for years before anyone thinks to look at the medication. For nerve pain, alternatives like duloxetine or gabapentin carry far less anticholinergic burden. And for mood, modern SSRIs like sertraline are significantly safer for aging brains. Number 3, antipsychotics. I need you to pay very close attention to this one because what I am about to tell you is something that happens every single day in nursing homes, memory care units, and hospitals across this country, and most families never find out. Antipsychotic medications were developed for serious psychiatric conditions like schizophrenia or bipolar disorder with psychosis. They are powerful, brain-altering drugs with a significant list of side effects. But today, they are routinely prescribed off-label to elderly patients who are simply confused, restless, agitated, or difficult to manage. Not because they have psychosis, because they are inconvenient. I will say that again. There are seniors in long-term care facilities right now being sedated with antipsychotic medications, not for their own benefit, but for the convenience of an understaffed caregiving environment. The FDA issued a black box warning about this practice more than 10 years ago, citing an increased risk of death in elderly patients with dementia-related behaviors. And yet, the prescriptions continue. Neurologically, antipsychotics work primarily by suppressing dopamine, the brain chemical linked to motivation, reward, movement, and executive function. When dopamine is chronically suppressed in an aging brain, the results include flattened emotion, slowed thinking, impaired memory consolidation, and accelerated neurodegeneration. If you have a loved one in a care facility, or if you yourself are being prescribed medications like quetiapine or risperidone for reasons other than a documented psychotic disorder, ask direct questions. Ask why. Ask what the plan is to stop. Ask what non-medication behavioral approaches have been tried. You are entitled to those answers. Number 2, paroxetine Paxil. This is one that does not get nearly enough attention, and it genuinely should. Paroxetine, sold under the name Paxil, is classified as an SSRI, a selective serotonin reuptake inhibitor, the same family as Prozac, Zoloft, and Lexapro. And when people hear SSRI, they generally think safer antidepressant, modern, better tolerated than the older medications. That is true for most SSRIs. Paroxetine is the exception. Unlike every other SSRI, paroxetine has significant anticholinergic activity. That one pharmacological quirk separates it entirely from the rest of its family. While Zoloft and Lexapro leave acetylcholine largely undisturbed, Paxil interferes with it in a way that much more closely resembles the older tricyclic antidepressants. The American Geriatric Society has placed paroxetine on their Beers criteria, which is an official list of medications considered potentially inappropriate for older adults, specifically because of this cognitive concern. The frustrating part is that paroxetine is often prescribed specifically to older adults for anxiety and depression, which is exactly the population it poses the most risk to. The solution is straightforward in concept. If you are on Paxil and you are over 60, ask your doctor whether switching to sertraline or citalopram might offer the same antidepressant benefit without the anticholinergic cognitive burden. Most patients make the transition successfully with a careful, gradual taper. Number 1, anticholinergic polypharmacy, which is what happens when multiple medications combine. All right, we have made it to number 1, and I told you at the very beginning that number 1 was not going to be a single medication. I want to explain exactly why, because I believe this is the most important thing I will say in this entire video. Each medication on this list, taken on its own, might produce only mild and barely noticeable cognitive effects in some people. A little more brain fog, a little more forgetfulness, easy to dismiss, easy to blame on age, but here is what actually happens in the real world. Older adults do not take one medication. The average American over 65 takes 4 or more prescription medications every single day. Many take 6, 8, 10 or more. A combination of prescriptions, over-the-counter products, and supplements, often prescribed by multiple different doctors who may not have full visibility into what the others have prescribed. When several of those medications carry anticholinergic properties, they do not simply add to each other. Research suggests they can multiply. A study conducted at the University of Washington, tracking more than 280,000 older adults, found that those with the highest anticholinergic burden, measured using a validated scoring tool called the Anticholinergic Cognitive Burden Scale, had a 120% higher risk of developing dementia over a 10-year period, double the normal risk from pills. Pills that most of them had never once been warned about in terms of cognitive risk. Let me show you what this actually looks like in real life. Picture a 72-year-old woman. I will call her Dorothy. She takes Benadryl PM every night to sleep. She takes oxybutynin for her bladder. She was recently prescribed amitriptyline for nerve pain in her feet, and she takes an over-the-counter heartburn pill every morning. 3 of those 4 are anticholinergic. According to each of her separate doctors, every one of those medications is appropriate and safe. But taken together, her anticholinergic burden score may fall in a range clinically associated with significant dementia risk. And not one doctor, not one pharmacist has done that math on her behalf. This is not a hypothetical scenario. This is Dorothy. This is Carol from the beginning of this video. This is your neighbor, your mother, your spouse. The medical term for this is polypharmacy, specifically anticholinergic polypharmacy, and it may be the single most underreported driver of dementia-like symptoms in the elderly population today. And now, here is what I want you to hear, and I want you to hear it clearly. Drug-induced cognitive decline is often reversible. I have seen it with my own eyes. When the medication burden is identified and systematically reduced under proper medical supervision, many patients experience a remarkable recovery of mental clarity. Memory comes back, personality reemerges. The fog lifts. Your action plan. Here are 5 concrete steps you can start taking this week. Step 1, write down everything you are taking. Prescription medications, over-the-counter products, supplements, sleep aids, everything. Do not leave out the PM pain reliever you take occasionally or the allergy pill you have been using for years. Step 2, look up each item on the Anticholinergic Cognitive Burden Scale, abbreviated as ACB. This is a free, publicly available tool that scores medications by their level of anticholinergic risk. You can find it online with a simple search. Step 3, schedule a medication review with your primary care doctor. You can use this exact phrase, "I would like to schedule a medication review to assess my anticholinergic burden." A good doctor will not be offended. They will appreciate the initiative. Step 4, ask specifically about deprescribing. This is the intentional, supervised process of tapering off medications that are no longer necessary or that carry unacceptable risk. It is a legitimate and growing field within geriatric medicine. Step 5, if your doctor dismisses your concerns, get a second opinion. You are not being difficult. You are being responsible about your own health. A geriatric pharmacist, and yes, that is a real specialization that exists, can also perform a comprehensive medication review on your behalf. Your brain is not a passive victim of aging, and millions of older Americans are living with symptoms that are actually entirely preventable and even reversible if caught and addressed properly. The 9 medications we talked about today, from the Benadryl in your nightstand all the way to the hidden combination of multiple anticholinergic drugs working together, can all be reviewed, discussed, and with the right medical guidance, replaced or adjusted so that your brain has the best possible chance to function at its best. You do not have to accept brain fog and forgetfulness as an unavoidable part of life. Talk to your doctor, bring your medication list, ask questions, and remember that your brain deserves to be protected at every age. If this video helped you today, please share it with someone you love so they can be aware and avoid the risks we talked about. Hit like so this video gets recommended to more people, and subscribe so we can meet again for the next piece of health advice. I am Dr. Saul Whitman. Thank you for spending this time with me. Stay sharp, keep learning, and I will see you in the next one.